Our next presenter is dedicated in managing our patients' medications and their immunotherapy side effects. Her wisdom and knowledge in oncology pharmaceuticals always leaves me speechless. She's a PharmD clinical instructor at CU and our clinic's pharmacist. So please help me welcoming Christina Davis.
Good morning. Can everyone hear me okay? That was also like the nicest introduction I've ever received. So thanks, Sarah. So like Sarah mentioned, I'm the clinical pharmacist for our cutaneous oncology clinic. So I have the privilege to work alongside all of these amazing people. And so today I'm going to be focusing on a new drug that was recently approved in January for metastatic uveal melanoma, which a lot of people may or may not be familiar with. It's called tebentafusp. And there are many different accrediting bodies that basically identify all of these things that patients really should know and understand prior to going into a new treatment. And so I'm going to try and highlight really kind of the most important ones today regarding tebentafusp specifically. And so that really focuses on the patient understanding their disease state, understanding the drug's mechanism of action, how it's given, so dosing, administration, and of course, side effects, how side effects present, how side effects are managed, which is really where I come in, which Sarah mentioned. So just a little bit of background, which again, I think it's very important for patients in general. And to be honest with you, all of our uveal melanoma patients are like super on top of it. They always come in like very well versed. They do a lot of research ahead of time. But for anyone who's not super familiar with uveal melanoma, it actually arises from the pigmented melanocytes in the eye. So many people are familiar with cutaneous melanoma, but are not as familiar with ocular or uveal melanoma. And so this most commonly arises within the choroid. That's 85 to 90% of cases. However, less commonly can also arise within the ciliary body and the iris. It is the most common primary intraocular malignancy in adults. And I think probably the most important thing to know is that this is very, very different from cutaneous melanoma. And so when you think about like normal targeted therapies that we use in cutaneous melanoma, which I've listed some of the targets here. So things like BRAF or NRAS or KIT are almost never seen in uveal melanoma. So that's very important to know. The other important thing is that these melanomas typically have a very low mutational burden. And so they really don't respond to traditional immunotherapies the way that cutaneous melanoma would. So despite aggressive therapy of the primary lesion, most of these patients, about 50%, will actually develop a metastatic recurrence. And this is most commonly to the liver. And unfortunately, up until tebentafusp, there was really no treatment that ever showed a survival benefit in metastatic uveal melanoma. So this is really just for your reference, just to show. So like I said, the majority of cases develop in the choroid, that's here. However, less commonly, they can develop in the ciliary body and also within the iris as well. So this is the New England Journal of Medicine paper that was presented, I think, September of last year, actually. And then tebentafusp was then approved January of this year. So just very quickly going over the mechanism of action for anyone who has never heard of this drug or who is not familiar with it. It's called a bispecific T-cell engager. There are other bispecific T-cell engagers in other cancer types. However, this is the first that's ever been used in melanoma. It specifically targets this HLA-A0201. And so you can see here on the right-hand side, it's a soluble T-cell receptor that binds to CD3. This is the T-cell here on the bottom. And then this also binds to GP100, which is presented on this specific HLA subtype on uveal melanoma cells. And so this really enables or acts as a bridge between the T cell and the cancer cell to allow those T cells to attack and kill the cancer cells. The number one most important thing that all patients have to know is these patients have to be tested for this HLA subtype before they can be treated with tebentafusp. And so I bolded that here. HLA testing must be done prior to initiating therapy, and it can only be used in patients that have this specific subtype. This specific subtype occurs in about 50% of all uveal melanoma patients. And so this drug was evaluated in an open label phase 3 study. This was pretty large, actually, thinking about metastatic uveal melanoma, the largest to date. And the primary endpoint was overall survival. Really, the most important thing to know here is that they were randomized to either tebentafusp, which you can see here, or investigator's choice, which is either pembro, ipi, or dacarbazine. And the majority of patients were given pembro on this study. And so you can see here, this is the Kaplan-Meier curve. The overall survival was statistically significant in favor of tebentafusp. It was about 6 months longer. You can see the hazard ratio and the p-value here, and this was seen across all subtypes. So tebentafusp has now made its way into the NCCN guidelines, which is great for me as a pharmacist, helps a lot with payer reimbursement and getting drug covered. And so this is really recommended in addition to clinical trial for any patients that have that HLA subtype. So in terms of dosing and administration, this is really where this drug gets very complicated. So it's given as a weekly infusion, which in itself for a patient to come in every single week is a lot. And we get referrals from patients all over the state. We get patients that are out of state. So coming here every single week can be very taxing. So making sure that patients understand the treatment landscape is very important. Patients receive what's called like a ramp up phase. And so the very first dose, this is a flat dose, regardless of who you are, what size you are, everyone gets the same dose. So it's 20 micrograms the first week, 30 micrograms the second week, and then 68 micrograms the third week and beyond. I will go over a lot more of the monitoring, which is down here. But for the first 3 doses, patients do require a 16-hour observation period. And we'll go over why on the next few slides. And then thereafter, they require a 30-minute observation period. So in terms of side effects, there is a black box warning for cytokine release syndrome for this drug. So when you think about how this drug works, you're basically activating all of these T cells to go in and kill all these uveal melanoma cells. And so this can basically create a systemic inflammatory response where you're having this release of cytokines into the bloodstream. And so there is a black box warning for this. The most common side effects of cytokine release syndrome I've listed here. So fever, dyspnea, hypotension, hypoxia are really kind of the most common things. You can also see elevations in LFTs, rash, and headache. I think probably one of the most important things to know is that this is generally reversible and managed with supportive care. So things like IV fluids, NSAIDs, sometimes corticosteroids if needed, very rarely, but in rare cases, you can need vasopressors. These symptoms are usually very quick to come on. So they usually present within the first 8 hours of giving the treatment. And so that's why for the first 3 doses, patients have to be monitored for at least 16 hours because in general, you will probably see some sort of side effect at that point. The highest risk is with those first 3 doses. Like I mentioned, the overall risk of cytokine release syndrome is high. It was 89%. That's any grade or any side effect of cytokine release syndrome. So the vast majority of patients will develop one of those symptoms. However, as you can see, the risk of grade 3-4 toxicity was very, very low. This was only 0.8%. The original study, it was 2 patients. And so the discontinuation rate was 1.2% as well. So very low for the percentage of people that actually develop some type of cytokine release. However, it is super important that these patients are monitored very closely. So fluid status, vital signs, oxygen status, they really have to be monitored every 4 hours when they are in that 16-hour observation period because of this. Because in the very rare chance, it can potentially progress very quickly to something more serious. Rash is the next most common side effect. So 83% of patients develop some type of rash. This is what we call an on-target off-tumor side effect, meaning that this actually occurs because normal healthy melanocytes can also express GP100. And so tebentafusp, which targets GP100, can also act on normal healthy melanocytes. So many patients get a rash with or without some pruritus. So we've seen patients get some pretty bad pruritus as well. 18% of those were grade 3-4, and 0% of patients had to discontinue treatment due to a rash. Treatment is typically just with antihistamines and topical steroids, making sure that patients are going home with everything they need, making sure they have these at home if they do develop a rash when they're not here. Rarely patients required systemic steroids, but for the most part, these rashes will resolve on their own without systemic steroids. Again, these often occur early in treatment and severity decreases over time. And this was actually something that they noticed was associated with improved overall survival. So they definitely didn't power the study to look at this, but they went back and looked and said, hey, patients that got a rash actually had a longer overall survival than those that didn't. And so super close monitoring, again, a ton of patient education when they're going home after that 16-hour observation to make sure that they have everything they need if they do develop a rash at home. The next side effect is hepatotoxicity. So 65% of patients saw some elevation in their LFTs. 22% of those were grade 3 or 4, and 0.4% of patients did have to discontinue due to this. I did make a note here that, as we know, metastatic uveal melanoma most commonly goes to the liver. So 94% of patients did have pre-existing liver disease on this study. And 73% again occur within the first 3 infusions. So they typically occur early on, and then that risk goes down after. And anyone that did have one of those more severe LFT elevations typically improved to grade 1 within 7 days. They did note that 27% of patients saw an elevation in their bilirubin, which is a little bit different than what we see with like immune checkpoint inhibitor hepatitis. However, most of these they did attribute to patients' progression of disease or involvement of their disease in the liver. And then there are a small percentage of patients that actually developed LFT elevations outside of the cytokine release syndrome, those first 3 infusions. And the median time to onset for that was 129 days, which is very delayed. And so that is really, again, why we need to be doing a lot of education and also making sure that we're continuing to check labs, not only at baseline, but throughout treatment as well. So in general, in terms of safety, this is usually what I tell patients. So overall, very few patients had to discontinue treatment due to side effects, although side effects can potentially be severe. It is rare. The most common are listed here. So CRS and rash are really the big ones. They can have, again, some pruritus with that, as well as fatigue, nausea, et cetera. And then the other important thing is that these are generally predictable and manageable. So unlike traditional checkpoint inhibitor toxicity, which is generally unpredictable, with these, we can usually tell if and when they're going to happen and manage them fairly well. And then this, I think, is just a really good slide to look at patients. I think this is really good for patients to look at too. It's just more of like a visual to see really the percentage of people that are going to get side effects. And so you can see here, it goes by week. So week 1 and across. Week 1 and 2 almost look identical. So the risk of getting some sort of toxicity is pretty similar. The light blue is the grade 1 and 2. So those more mild to moderate side effects. And then the more serious ones are listed in the blue. So you can see here, the risk of cytokine release syndrome for the first 3 doses is here, and then it drops pretty significantly. And then the next one we have is rash, again, pretty similar between weeks 1, 2, and 3, and then starts to go down pretty significantly as well. This is something that I feel like is often missed in patient education. I think a lot of people don't talk about it as much as we should. I think probably, like a lot of you have mentioned, historically, we haven't really had patients where we've talked a lot about like family planning in the future. And now we have treatments where we do have to start thinking about those things. So if you do have a female of reproductive potential, they absolutely have to be using effective contraception during this treatment. And for 1 week after the last dose. So that's very important, as well as breastfeeding. So no breastfeeding during treatment or for up to 1 week after the last dose of tebentafusp. So in terms of education take-home points, so all patients have to be tested for their HLA subtype prior to starting treatment with tebentafusp. The risk of CRS is high. Like I said, about 90% of patients develop some type of side effect from CRS. However, the frequency and severity does decrease after the first 3 doses. And so really, I think probably the biggest thing that we've seen and the challenge that we've run into is how are patients going to be monitored for 16 hours? A lot of facilities don't have an infusion center or an outpatient facility where patients can just like hang out for 16 hours. So the way that we have mitigated this is by actually admitting the patient into the hospital for observation. I think a lot of centers are probably doing something similar. And so really setting that expectation with patients so that they know and understand what treatment is going to look like is very important. So they'll likely be admitted and watched overnight for the first 3 doses. If everything goes well and they don't have any serious side effects, then doses 4 and beyond are typically given outpatient with a 30-minute observation period. This does require extensive care management, which we have an amazing team that does a lot of that. In general, you 100% have to have protocols in place for the identification, grading, and treatment of cytokine release syndrome. And so really being in a facility that can manage a lot of those things is super important, as well as having a plan of escalation of care. So really telling patients there is a very small but serious chance that something could happen where you do need to be transferred or in a place where, you know, they can give you something to help maintain your blood pressure, et cetera. This is given as a once weekly IV infusion. So again, once weekly. So pretty time consuming for patients in general. And again, just having an idea and a plan of where this is going to take place within the facility. A lot of people ask about pre-meds. Pre-medications are not required initially. So unless a patient has a severe episode of CRS or they have a moderate CRS that's persistent, then they do recommend pre-medicating with dexamethasone prior to the following doses. Again, extensive coordination and transitions of care really becomes key with this. And again, setting expectations with patients about what that is going to look like is also very important. As well as monitoring. So a lot of patients are like, what am I going to do when I'm in the hospital? Like, am I just going to sit there? Like, what is that going to look like? And so kind of reviewing what the monitoring parameters are, what they're going to be doing and looking for, and making sure that they have everything that they need going home is also very important. This is another thing that has come up quite a few times. So our patients that have been on treatment for a while and are coming in every single week, they work and they travel and they have lives outside of here. And so it's come up a few times about what to do if patients miss a dose or miss a few doses. And as of right now, there's really no published information from the manufacturer about what to do if that happens. Like, do they need to go back to the starting dose and then re-ramp up? Do they need to be admitted for that? What does that look like? And so the drug company has really told me that I should direct anyone to the drug company if that comes up, and then they will basically guide you about what to do and what the best course of action is. So if you ever have a patient where that's the case, you can contact Immunocore directly and they will provide guidance on that. And with that, I will take questions.